Good morning. My name is Ryan Padrez. I'm a faculty member in our General Pediatrics Division here in our Department of Pediatrics. Really have the distinct pleasure to serve as the moderator for this panel with some terrific speakers for us this morning. I also have the distinct pleasure of volunteering and serving on our MCHRI Education Committee that helps to plan a lot of events like this. And so for faculty that want to get more involved, check it out. It's a great committee of faculty and fun way to get to know folks across the university. So to lay out the agenda for today, it's a packed agenda where each speaker will get about 20 minutes to share some of their work and research, and then we'll leave about 4 minutes for Q&A. We have a guest speaker here who wants to share some concluding thoughts here at the end of the panel, so we'll make a little bit of time for that. So to get us on time and started, let me introduce our first speaker, Dr. Igbinosa. She is a maternal and fetal medicine physician and assistant professor in our Department of Obstetrics and Gynecology. And she'll be sharing work about advancing nutrition in iron deficiency anemia care in pregnancy, a multi-modal approach. Come on up. Thank you.
All right. Good morning, everyone. Thank you for having me. And so I'll just go ahead and get started. Okay. All right. So first, I like to start with my acknowledgments and gratitude. And first, thank the MCHRI, who has funded me for several projects. You'll see my clinical trainee grant, my master's of epi, as well as my community engagement research, my community advisory board, our department in OB-GYN, as well as the Office of Faculty and Development, and several community partners who helped some of this work, mentors and mentees, as well as my NIH K-12. So iron deficiency is the most common cause of anemia in pregnancy. And often when patients describe anemia, they describe something akin to this image, just feeling very fatigued. They can still function, similar to your phone, but they're not at full mass. And anemia in pregnancy affects about 1/3 of pregnancies globally, 1 to 2 pregnancies for every 10 in the United States. And it is a source of disparities. 1 in 5 Black pregnant women in the United States have anemia. And so here is a time periods when women, or reproductive age women, are most vulnerable to iron deficiency. And it really starts with menstrual cycles. There's about a 23 milligram basal loss of iron. And then during pregnancy is another period of time where it ramps up, about 220 milligrams loss, and then 600 milligrams loss of iron with delivery. And so that's not accounting, what stores that patient may come in with. And so at the bottom, something that I think is very important for people to understand is that iron deficiency affects 50% of pregnancies in a high-risk resource setting. So often when we think about iron deficiency, we think about low-resource countries, et cetera, but it is something that we're seeing in our population here in the U.S. And so what are these drivers of iron deficiency anemia? So I talked a little bit about menstrual history. If someone has heavy menses, they have fibroids, abnormal uterine bleeding, those things can increase iron loss. And then there's food insecurity. Most people of childbearing age have a dietary intake of iron that is too low to offset menstruation and pregnancy. And so a lot of people are coming in with a deficit to pregnancy. In terms of food security, 24% of pregnant people have food insecurity. There's structural inequalities. Prior to 2021, there were different cutoffs for treatment of anemia by race and ethnicity that was not in any biological basis. And so basically what happened is that Black women received treatment at lower hemoglobins compared to white women. And then social determinants of health. And then also OB history. So if they had short interval between their pregnancies, maybe this is a multi-fetal, twins, triplets, or they've had several pregnancies. All of these things can cause drivers of iron deficiency. And then these have consequences to mom and to baby. So for mom, we know that it increases the risk of cesarean delivery, blood transfusion, postpartum depression, severe maternal morbidity and mortality as defined by the CDC, and morbidity being a near-miss event in pregnancy. And then we know that neonates are at risk for preterm birth, low infant birth weight, perinatal mortality, and neurodevelopmental delay. And so what I will talk about is the different ways that we've approached or looked at this issue. And so first, from an epi perspective, our initial questions are, what are the current trends of anemia? And can we look at that by race and ethnicity? And how does anemia contribute to the disparities that we see in severe maternal morbidity? And so this is research we published. I have Stephanie Leonard down there who worked together closely on this project. And what you could see is that we looked at almost a decade of births in California, over 4 million births. And you can just at a glance see that iron deficiency anemia increased for everybody. And then the most affected were Black pregnant women, followed by Pacific Islanders. And then you could see that a disparity persisted over time between Black and white patients, and the white being the white patients, pregnant patients being the lower line. And then the other thing that we looked at is population attributable risk. And so what is our best estimate of this anemia to severe maternal morbidity? And that we saw for all populations by race and ethnicity that anemia can contribute to that severe maternal morbidity. And the highest contributor were among Black and Hispanic pregnant women, where anemia contributed to about 1 in 5 pregnancies having severe maternal morbidity. But even on the lower affected, we see white patients, about 15. Anemia contributed to 15% of severe maternal morbidity. And so with our next kind of set of questions is a project called HEAL, where we wanted to look at qualitatively what are the patient experiences with anemia and nutrition in pregnancy, especially with those most at risk. And can we partner with community-based organizations, advisory boards to understand patient experiences? And so this was important to me in particular because I think in terms of us understanding disparity-related issues is like trying to disentangle the story. And so this first work, Patient-Centered Voices of Anemia, where with our PI for this project was Dr. Lyle, and we worked with our community partner, Black Wellness and Prosperity. And so we asked women with anemia what were the challenges that they were seeing on their end. And then this qualitative interviews of over about 15 to 20 patients. These were our main themes. Patients felt that they were dismissed. I always feel tired, but every time I would tell the doctor, it was always being diagnosed as, you're pregnant. Counseling, general information. I made some dietary changes, but I don't feel like I really had the doctor's office checking on me. They never asked me to make dietary changes. And then patient experiences with the diagnosis. And the way she explained it, I didn't understand it, but I pretended I did. And then treatment challenges with those iron pills. Oh God, I don't like this, which we hear a lot actually. And so altogether, I just stopped taking it, which we have data that over 70% of women who take oral iron discontinue it in pregnancy because of the side effects. And so then our next study, HEAL, exploring healthy eating approaches among Black pregnant women, we conducted 30 semi-structured interviews and also did a USDA food insecurity survey to discuss, well, what nutrition counseling did you receive? What was your dietary practice? And did the same kind of inductive and deductive reasoning for thematic analysis. And our themes were similar. Specifically for anemia, lack of nutrition advice. I had to navigate it on my own. Nobody ever talked to me about that during my pregnancy. Self-perception of healthy eating, and sometimes I feel bad about eating more. Am I really hungry, or am I just eating because I want to eat? Structural challenges to healthy eating. To be completely transparent, I feel like my diet quality is very poor just because of my current living situation. And then patient-led research. My doctor, TikTok, Instagram, and then my husband, my mom, and friends. And just to be clear, the standard of care that every patient should be receiving is nutrition counseling, and if they have a diagnosis of anemia, is oral iron. And so then we also looked at patterns of food insecurity and iron deficiency anemia among Black women. And the red being those with participants with iron deficiency anemia, and the blue being without. And even though the difference wasn't statistically significant, we found that very low food insecurity was more common in iron deficiency anemia patients versus non-iron anemic patients. And then in other data, we saw that these differences persisted even in those who were WIC participants. And so we had a community advisory board, 7 women with a wide range of expertise of nutrition and pregnancy. We had nurses, doulas, advocates, mothers. We also had ASL interpreters for hearing impaired, and we met regularly and followed the theory of change model. In terms of a community-based participatory approach to understand what does the community also want to see. And so they wanted us to incorporate community health workers and doulas into prenatal nutrition education. They wanted more avenues to educate the community on the importance of nutrition, anemia, and they wanted us to collaborate with existing efforts. And so that leads us to the next project, which is Nourish, which is prenatal nutrition education workshops with doulas and community health workers. And that included of 2 didactic sessions led by myself and a registered dietitian, and we also had a teaching kitchen. Participants completed at baseline a pre and post generalized nutrition knowledge questionnaire revised survey on nutrition, and then we compared the scores. And then on the kind of the different logos you see are all our partners that we had for this particular work in terms of reaching and making sure that we were actually in communication and in community with the doulas that were actually could deliver the intervention. And these are just some photos from our teaching kitchens, which was done at a community site. Led by Jocelyn Dubin, our registered dietitian with the county. And a lot of our focus was on low resource, so could our grocery list be reproducible for somebody who maybe has limited resources, and then meals that could be expanded easily based off on family size. And that was based off of direct feedback from our families. And so our preliminary findings was that, people learned. Community-tailored nutrition education improved among doulas and community health workers. And then the survey, which I won't go into detail today, but it has many domains. And then all the domains improved except for food selection. And we did separate focus groups to talk with our participants on what are the challenges that they had with clients and talking, and really came down what do we eat? How do you tell someone to pick out food based off their preferences? So future area. And so then that leads us to our RCT that we also did on anemia, because we still have questions, right? We've looked at the epi, we've looked at to see the distribution, we've talked to patients. I didn't include in this presentation for time, but we also talked to providers to understand from a provider perspective, what do you think the challenges are? And I will say briefly, there's evidence that only 50% of providers actually appropriately screen and treat for anemia. And then the other thing, just to summarize from providers, is that they wanted other treatment options. I mentioned earlier that the standard of care is nutrition plus, oral iron for everyone. And so our question was, nutrition counseling is ideal. Of course, it makes sense, especially if it started early. But is it likely to prevent anemia for someone who's starting iron deficient, who is now, growing a fetus? You need more. And then oral ferrous sulfate is the standard, but there's a lot of non-compliance. Or maybe is it just not the best option given the GI side effects for people later in pregnancy? And so our question is, what are the options for pregnant people with anemia in the later half of pregnancy? Can we build a case for IV iron for anemia in the later half? I will say in the US, There's the only standard for IV iron right now is if someone is unable to tolerate oral iron, which is separate from our colleagues in the UK, where it is standard to give IV iron for pregnant patients over 34 weeks with iron deficiency. So we conducted a randomized clinical trial comparing IV iron. Our iron of choice was pramoxetol with oral iron, which is ferrous sulfate, in pregnant women to 24 to 34 weeks. And the reason that we picked the third trimester is because then this is a window where, unlikely the other things that we mentioned earlier, are able to have an effect before delivery. And so our outcome was, did the hemoglobin change over 4 weeks post-treatment? And then the secondary, which is more kind of clinical relevant, is did anemia resolve prior to delivery? And so we stratified our patients by severity of hemoglobin. So hemoglobin from 9 to 10.9 or 7 to 8.9. And they either got pramoxetol 510 milligrams or oral iron 325 milligrams. And then for those more severe, they got 1020 milligrams or oral iron 650. And inclusion criteria were pregnant patients with laboratory confirmed iron deficiency anemia. With a singleton pregnancy. And then we had several exclusion criteria here, and we were registered on clinicaltrials.gov. And so this is kind of a study timeline from enrollment to delivery, where we collected laboratory indices. We also did a survey on patient-reported outcomes, and we monitored for adverse effects. And our sample size, based on the estimated effect size of increase in hemoglobin, was about 80. And we did an intention to treat analysis. And so over 4 years, we screened our clinic patients, about 3,000 clinic patients. 1,000 had a hemoglobin definition of anemia. And then eligible by iron deficiency lab criteria was 279. I will say an asterisk we learned is that not everyone confirms the actual type of anemia. So that was another source of education in our clinic to if once someone's anemia, see what kind it is. And then we were able to randomize 83, and 3 had to be excluded post-exclusion for early delivery, etc. And so in this table, you can see just our baseline characteristics. And essentially between the oral and IV iron groups, that the groups were kind of well matched and even, except a slight change in BMI between the two groups. And then for our primary outcome, what we saw was that in that 4-week period with the one dose of IV iron pramoxetol compared to oral iron, there was a significant change in hemoglobin. And so the change from enrollment was about 0.4 grams per deciliter in the oral iron, and then 1.05 grams per deciliter in the IV iron. And then the graph here kind of illustrates the range wider. And then for the other question, okay, we changed hemoglobin, but did we resolve anemia? And we did. In the IV compared to oral iron group, about 93% had resolution of their IV iron compared to 65% with oral iron. And so it was more likely, resolution was more likely for the IV iron in this later part of pregnancy. And then we also, I mentioned the survey, looked at patient-reported outcomes. 76 participants completed it, and we noted that in the IV iron group, patients reported improvement in energy and fatigue with a median increase of about 10 points. And then I just have a sample. We did a mixed methods analysis of the free text responses. And the first box of energy is the IV iron. And I really enjoy this quote, but following the infusion, my mom observed a noticeable transformation. I appeared revitalized with a healthy flush to my cheeks. And in the oral iron, I did not feel results when taking oral iron as prescribed. I was usually weak and little to no energy. So putting all the pieces together of work thus far. So quantitative, we've learned that anemia in pregnancy is common. We've actually noted that the prevalence of anemia is higher in what we've been able to, than older literature, that it's actually more common than previously understood. From HEAL, we learned pregnant people desire more education on nutrition and treatment options for anemia. From Nourish, we learned that doulas and community health workers are a potential source of community prenatal nutrition education, because we understand that all of this will not happen in a provider's office. And then from Anemia, the RCT, we learned that IV iron is a viable option for patients in the later half of pregnancy. And so there are opportunities for future studies to provide patient-informed, evidence-based protocols for the management of anemia in pregnancy. And so I saw my warning there. So what's next is we keep going, we expand. And so for Nourish, our prenatal nutrition education, we are expanding that to our pregnant patients with our centering program in our clinic. For our community health workers and doula, we're doing longitudinal to see over time, did that nutrition knowledge sustain itself? Were they able to kind of disseminate that to others? And then from our Epi, we want to also look at maternal anemia and neonatal outcomes. And can we say anything about that more robustly? And then on the side here, I have PRISM, which is our, I'm blanking on the new name, promoting improvements in hemorrhage-related, severe-related maternal morbidity, but using implementation science to say that, hey, we have this evidence. How can we put it together in a way that actually changes clinical practice? And more importantly to us, clinical outcomes. Because what started this story was that anemia is common and it contributes to maternal morbidity, it contributes to preterm birth, and et cetera. And so with that, thank you.
I've got one while people are having. So I'm really intrigued by the IV iron options for women, and I'm wondering, you mentioned England offers it as a standard of care. Do you know, I know our friends at NICE love cost-effective analysis. Has anyone started looking at the cost-effectiveness of IV versus oral, in particular when thinking about the prolonged hospital stay for women, transfusions that happens in the nursery and others that could happen?
Thank you for the question. So people have looked at it with the older generations of IV iron. So the older generations, you often needed 3 or 4 visits to get someone to a normal level. And with the newer generations that maybe some of you guys use in your population, you just need 1 dose, maybe 2 doses. And so, but even with the older generations, it was still cost effective. And so the thought is that now that we're moving to shorter infusions, shorter length of time, it is likely to continue to be so, but we just need to prove that.
That was just a phenomenal example of taking one thing that's well established, anemia, and then just going from the idea, implementation science, and then the trial, and then implementation. What are your thoughts about not just anemia, but other types of things you're identifying for mothers that you're looking at, or potentially could be applied? What are the low-hanging fruit that besides anemia that might be the next 100 things that PRISM group might be looking at?
That's a good question. I think if I were to think about it broadly, I would think about what is it that we know should have benefit and people aren't utilizing. And one example would be vaccines, where we know there is benefit to reducing outcomes, like you think about COVID or the RSV vaccine, but the uptake of it may be limited. And so those are a few examples that come to mind.
Perfect. Well, thank you so much. Great. Our next speaker is visiting us from the California Department of Public Health. Dr. Cindy Wu is the director there of in the Program and Policy Branch at the Center for Family Health and Genetic Disease Screening Program. And she's here to talk about her work called The Circle of Connection, Advancing Genetic Screening Parity in California. Dr. Wu, thank you for being here.
Thank you so much. I'm going to move this down. Yeah. I am delighted to be here and delighted to discover the MCHRI, and because I believe both of our organizations align in our mission to provide quality of care in the life course continuum from prenatal to neonatal stages of life. And I want to show you how you are already part of this circle of connection and how we can advance genetic screening parity in California together. So how many of you realize that the genetic disease screening program has already touched your life? I want to ask you a few questions, and if you could entertain, please raise your hand if you were born in California after 1966. And please keep your hands up. How many of you were pregnant and gave birth in California? Please raise your hand. Thank you, and keep your hands up. And how many of you have treated newborns that have been diagnosed with a newborn genetic disease in California? Thank you. So all of you with your hands raised have been touched by the program, and you are not just audience members today, you are part of our story. Before I jump into my talk, I would like to acknowledge the talented data analytics team that provided the data today that I will be presenting. And I also want to thank my leadership for the insightful discussions that helped shape the equity-focused narrative today. So I will be talking about why population parity matters and give an overview of the California Genetic Disease Screening Program, GDSP, and the current state of parity, and talk about opportunities and future directions. So genetic conditions affect 3 to 5% of all births, and early detection can prevent disability and death. Screening services effectiveness varies by population and geography, and health disparities compound across generations. Here's what our data reveals. Despite advances in technological screening technology, as well as expansion of the panel, there are still disparities that persist. Black infants experience longer diagnostic delays and longer wait time to treatment initiation. And this is a failure of our healthcare system to translate technological advances to equitable outcome. And the gap between what we know works and what actually happens in practice is where families suffer preventable consequences. And this isn't a technology or knowledge problem. This is really an implementation and systems problem that we need your clinical expertise and leadership to solve. Our goal is simple but ambitious, is to ensure everyone has equal access to life-saving screening, follow-up care, treatment, regardless of zip code, race, or insurance status. So how are we positioned to do this? Let me introduce you to the foundation we are building from. So the GDSP is the largest screening program in the world. We service approximately 300,000 pregnant people in California, and we screen around 400,000 babies per year. We're one of 2 states that provide prenatal screening, and we have been doing newborn screening for the past 45 years. Our goal is early diagnosis and treatment, and our screening program has identified thousands of cases where we were able to provide early treatment to prevent severe disability or death. And this success provides the foundation of an even greater achievement. We're a proven coordinated system that can bridge your clinical and research expertise with our population-wide equitable outcome. Our system is more than just a test. We are a coordinated continuum of care. And our approach is comprehensive. Starting with education, we provide information to families before they need the screening. And our screening process is efficient and streamlined. And the key to our success is that we don't stop at just screening. We also provide timely follow-up, genetic counseling, diagnostic services. We facilitate treatment coordination and long-term evaluation. And we've proven that this coordinated care minimizes gaps and ensures that no one falls through the crack. This proven systematic approach has 5 key elements. Population health focus, which is designed to reach every family. We have a proactive outreach where we have multiple contact attempts with diverse communication. We have dedicated resources of case managers that follow through with each screen positive cases. We have standardized protocols that are consistently implemented regardless of family background. And we have a comprehensive support network to address barriers before they become delays. And the most important thing is that GDSP integrates a true continuum of care from prenatal to neonatal stages of life. So let's take a look at how this system has evolved over time. The prenatal screening program started in 1986, and this is an optional service that we provide to the pregnant people of California, where they have to opt in with a signed consent. And over the years, we've expanded the number of conditions, and we've modernized our processes to include cell-free DNA screening for trisomies in the first trimester in 2022, as well as adding an electronic order portal. And these advancements reflects our commitment to continuous improvement to provide quality care for the diverse population of California. So next, let's take a look at newborn screening program. The first genetic disease was screened in 1966, which is PKU. Our program was officially established in 1980, screening for PCH and galactosemia. And the difference between the prenatal program and the newborn program is that the newborn program is a mandated screening that we are required to provide to every newborn in the state of California, and parents can opt out based on religious concerns, reasons. And we now screen for over 37 core conditions plus 40 secondary conditions, including metabolics, endocrine, and neuromuscular disorders. In 2016, a statute was approved where we need to add newborn screening, a newborn disorder to our screening panel if it has been added to the HRSA recommended uniform screening panel, and we have to do that within 2 years. So since 2016, we've added new disorders every 2 years. And next year, we will be adding Krabbe disease in 2026. And so this October, we're celebrating our 45th year in providing this service, as well as celebrating screening over 20 million babies in California. So who are we reaching with our program? This slide shows a side-by-side comparison of California's childbearing population and our prenatal program participants. And our participant demographics largely reflect California's childbearing population, but the white individuals are slightly underrepresented. But demographic reach doesn't guarantee equitable outcome, as our next data on insurance and race will show. As I mentioned before, in 2022, we launched a modernization initiative where we added an electronic order portal for prenatal screening test orders. And this slide shows improvement after 2022 in case management in referral time and diagnostic time based on insurance type. For non-Medi-Cal participants, the time to referral from screen positive results went from 2 days to 1 day. And for Medi-Cal participants, the time to referral from a screen positive result went from 3 days to 1 day. So successfully achieving parity in time to referral. For time to diagnosis, non-Medi-Cal participants experience a 3 day, 2 to 1 day decrease in wait time for time to diagnosis. And for Medi-Cal participants, the wait time dropped 3 to 4 days. So we have proven that this coordinated approach works and that we have eliminated referral disparities and significantly reduced diagnosis time gaps. And we see similar patterns when we look at race and ethnicity. Next. So let's take a deeper dive into the diagnosis time by race before and after our modernization in 2022. For diagnosis time, we have achieved substantial gain for Asian and white participants. We saw a decrease in diagnosis time by 3 to 4 days. For Black and Hispanic participants, we have also observed a decrease in diagnosis time of 1 to 2 days. So the Black and Hispanic participants still experience longer wait time compared to Asian and white groups, which is concerning. But the good news is that we have proven that our approach works and that we can dramatically reduce disparity and eliminate them entirely for referral. And this success demonstrates that we can achieve the same equity for diagnosis time through continued partnership. Now let's take a look at newborn screening data. This slide shows time to diagnosis and treatment from birth for newborns with a confirmed genetic disease by insurance type. Notice both the median times and the wider variability for Medi-Cal patients. And between the process of diagnosis and treatment is when these patients leave the GDSP coordinated system of care and enter into the broader healthcare infrastructure for treatment initiation. And the disparities are even more striking when we look at race. So this is my most critical data slide that I would like, the point that I want to drive home, is that this slide highlights disparities in time to diagnosis and treatment for Black infants. I want to mention a caveat that Islander data set has very small sample size, so that it's not statistically significant, but for the other groups, the sample size is sufficient. And as you can see, Black infants experience longer time to diagnosis and even longer wait time to treatment initiation. So this is concerning, and this reinforces the need for targeted intervention, not just in screening access, but also ensuring timely and equitable care and to receive treatment. And this is where we need your clinical leadership. This is county level data on median time to treatment between 2015 to 2019 and 2020 to 2024, essentially before and after the pandemic. And there is geographical variation that most likely reflect the differences in healthcare infrastructure and access. We see a longer wait time to treatment for Yuba and Lassen counties between the two time period. However, in contrast, for Santa Barbara County and Contra Costa County, the wait time to treatment actually decreased, which may be because of easier access to treatment centers or a stronger provider network. So this is another insight to help us identify where we can focus our targeted support and systems improvements geographically. So just imagine if you're Black on Medi-Cal and live in Lassen County, the cards are stacked against you. And if you don't receive treatment, this is not just a missed opportunity. This could potentially impact your family for generations to come. So, what do we do with all this? Let's talk about what comes next. This is where our synergy becomes essential. We cannot eliminate these disparities alone, and neither can you. But together we can make the treatment delay for Black infants a statistics of the past. If you're a public health leader, like myself, we can implement equity-focused policies and invest in community-based interventions. My center will be launching a Black Birth Equity Action Plan next year. If you're in academia, you could facilitate cross-sector conversations such as this amazing symposium and help us design evidence-based solutions. If you're in healthcare, you can adopt equity strategies, train providers and community outreach coordinators, as well as engage payers such as Medi-Cal insurances to remove structural barriers. This isn't about one program fixing everything. This is really about all of us bringing our expertise to the table. And as we look ahead, there are some new opportunities and new responsibilities. I'm excited to hear about using AI for risk prediction, but I do want to be mindful about algorithm bias. I'm also looking forward to the use of genomic sequencing, but we must understand penetrance as well as appropriate interpretation of variants. And I see promise in telemedicine for rural and urban underserved areas, but we must ensure equitable access. Our commitment remains to continue to refine the California genetic screening system that serves all families with excellence. And just imagine California 10 years from now, that all families affected by congenital disorders receive equitable care regardless of insurance status, zip code, or race. And when your clinical expertise combines with our 45 years of systematic systems coordination experience, we can extend this success across the entire care continuum, from screening to treatment to long-term follow-up. And this is the future we're building together, where no family wait longer for diagnosis because of their race, where rural and urban families receive the same quality of care, and where every baby gets the early intervention that prevents disability and death. So GDSP has already been part of your story, whether you knew it or not. Now you have the opportunity to be part of ours. I want to leave you with 2 reflection questions. What barriers to screening equity exist in your community that weren't discussed here? And how do we improve on time to diagnosis for Black and Hispanic pregnant people and time to treatment for Black infants? So I welcome your ideas and feedback, and I'm happy to take questions. Thank you for listening and your partnership in this critical work.
Terrific. Thank you, Dr. Wu. Question?
Hi, thank you for that. I had a quick question just about the measurements that you talked about. For people who are referred, were there any people who were not referred, and were there systematic differences between those who had a referral and didn't have a referral? And I don't know if I missed that. And then your time measurements, I was just wondering, what's the start time? What are you going from? Is it time to diagnosis from the time of referral or from a different time point?
And you're referring to the prenatal
The last set of,
right?
yeah.
Or newborn.
Well, I guess both sets, where you talk about time to diagnosis and time to referral.
Okay, yeah, it's the starting point is for the prenatal data is starting at a screen positive result of either NTD or a sex chromosome aneuploidy or trisomy, and every case is referred unless they do not wish referral. So unless they refuse referral. So the data set I have here are just on those cases that have opted for referral, that have consented for referral.
Okay.
And for newborn data, it is from confirmed diagnosed case. That's the starting point for to diagnosis. Sorry. So actually screen positive to diagnosis, and then from a confirmed case to time to treatment.
Okay. Okay.
Does that answer your question?
Yeah, and I guess the follow-up just really quickly is, what were there differences among people who did not want to be referred?
We didn't look at people who didn't want to be referred because we don't have that data, because we don't have the time to referral data.
Oh, I
to
just mean,
compare
were they
to.
somehow systematically different with, like, based on the type of insurance or their demographics or any of the things that you
interesting.
talked about?
Yeah, that's a good question that we can look into more, definitely. Thank you.
Okay,
Thank you for that
thanks. Yeah.
suggestion. Good morning.
Hi.
Hi.
Well, first of all, thank you for everything that you do. This is one of the largest biological profiling data sets on the planet. And it's unique in California in that because of CMQCC and CPQCC, we are able to track these patients and discover new biology. And so thank you for all of that. It's a fantastic program. My question is about algorithmic bias in AI. AI in particular doesn't have its own biases. It just reflects what's happening in the society and what it's seeing in its training data sets, which comes from the biases that our providers and our healthcare system has. It just mirrors those and maybe provides an opportunity for seeing them. When there's this complex interplay between human bias and AI algorithmic bias, where do we begin? How do we address that?
Yeah, that's a very good question. And you and I had a brief discussion yesterday about it. And it's very complex to think about. And I thought about it a bit more yesterday after our conversation. And I think there's potential for AI to sort of make corrections for those biases. And, if the data set going into it is already biased, if we can be aware of it and make corrections or do sensitivity analysis, and to, like you mentioned yesterday, like small steps that we can do to correct the bias, that would be ideal, and it would be, I think it would be great to see. I would be very interested in seeing that, and potentially, discussing more afterwards about how we can actually implement that or, look into that. Yeah,
Thank you.
thanks.
Great.
Thank
Last
you for the
question.
Cindy, thank you for coming and joining this session with us. I was going to ask something very similar to Nima and suggest that, having a human in the loop is a good thing. And these tools that we are using, we have to understand how they work and how they can be biased and so forth. And we work on that in various settings. The other important point I wanted to emphasize, which you presented to us, is that it's now really important for us to focus on communities. Communities are different, not only in their demographics, but how they think about problems, their leadership structures and everything else. And to solve these problems, I think that what becomes clear from your data is that ability to now look at the community level, at our practices and so forth, and help them understand how to ensure that we have parity as you're moving forward. The final thing I'd just say, and Nima I thought was going to comment on this too, is that the data that our state has collected, which is tremendous, you're to be complimented, and I'm just really proud of what our state does, gives us a lot more information about how we can predict other outcomes which are acquired as these different individuals confront environments which again differ by community. So I think we have a lot more to achieve together.
Totally agree. And I just want to say, that human or AI will not be replaced by humans will not be replaced by AI, and that there's always going to be a human factor involved in this risk prediction. And so I think that's the key, that we need to recognize when there is a bias, and we need to determine when to put in that correction. And to your comment about community engagement, I completely agree. I think there's a lot of health literacy work that we can do from my organization. In addition, I think there's the misinformation and the knowledge gap is how do we fill those knowledge gaps so that people don't have misconception of what the public health department does or what AI does, because there's a lot of irrational fear, about what the public health department is doing or what AI is doing. And so how do we work together to fill that gap, that knowledge gap? And I do look forward to working with everybody here on future discussions on that.
Thank you.
Thank you.
Terrific. Thank you, Dr. Wu, so much for coming. So really excited to welcome our next speaker, Dr. Carl Sylvester, who's a professor of surgery and pediatric surgery here at Stanford, but also notably the Associate Dean of Maternal Child Health Research at our School of Medicine, the co-director of Stanford's Metabolic Health Center, and the director of the Clinical Research Support Office for Stanford Children's Health, here to talk about his work on building a molecular framework for maternal newborn precision health. Welcome. Thank you.
Those titles, what I really like to do and get excited about is this stuff. So let's take a little talk here. Appreciate the opportunity to come and share some thoughts from the Education Committee, so I really appreciate that invitation. I'd like to do three things in the next 20 minutes. One, provide a conceptual framework for how we try to address very, very explicitly this idea of healthy moms and healthy babies and how they influence each other. Number two, I'm going to give you a case clinical vignette of how I think studies like this can impact clinical care today, and I think are moving in that direction. And then finally, number three, introduce some new tools where we're trying to do this bigger, bolder, faster, and stronger. And so we'll see where we go. So 2010, this was on the cover of a now extinct species, which is the print media. But having said that, what you see here is how the first 9 months shaped the rest of your life. Of course, the scientific community was well onto this concept for some time, beginning with the Barker hypothesis. But what it does indicate is that it became into the public or lay public's consciousness, right? Fast forward to almost to the day, 15 years, we now have, under threat here is the worldwide fertility rate is dropping to below 2.1, which is the replacement rate, if you will, if you're an Elon Musk fan. The advanced maternal age, 20% of currently of all pregnancies are greater than 35, which was a historical definition of advanced maternal age, and there's, again, a lot of reasons for that. If you combine the risks of the three biggies, preterm birth, preeclampsia, and gestational diabetes, about 1 in 4 to 5 pregnancies are going to experience one of these conditions, and so you can imagine the prevalence of these in combination. And then finally, despite a lot of work by many in the room, the preterm birth rate as just one indicator remains stubbornly high, greater than 10%, and 2% for those born extremely premature. So we've got a lot of work to do still. This comes as no surprise to anyone in the room, and probably many of the speakers have already addressed this, which is that any type of intervention early in life, particularly the first 1,000 days, is going to have a profound effect and return on that investment, meaning in quality of life over a life course. And I think really this concept, which is somewhat old, this was published back in 2011, and there was ideas, of course, that far exceeded this, and that the fixed genetic contribution is small, which means all the exposures and all the other things that you experience, including in healthcare that we do to our patients, has a profound impact on what's going to happen to them. And so one of the things that we struggled with when we began to think about this, focusing mostly on premature babies because we're, of course, at a quaternary children's hospital, and these are the types of things that we see, is that historical dogma really separated things by gestational age and birth, and gestational age and birth weight, particularly low birth weight and extremely low birth weight. And in reality, you would say, well, your risk for getting necrotizing enterocolitis if you're a 28-weeker and you're born at 1,000 grams is somewhere between 2 and 6%, depending on what unit you're born into. And it can be as high as 10 or 12% in certain referral centers. But in reality, what you have is a bunch of babies who are at varying degrees of risk, and sometimes these risks overlap, and we really can't discern them. On top of that, many of the diseases here are amalgamations of clinical findings. There's no specific metric of that. In fact, in our case, my passion diagnosis, necrotizing enterocolitis, there is no diagnosis. It's a staging system, which is called BELLS, and it's been in use since the 70s. And it's based on one X-ray finding. Absent that, you cannot convince, and I'll get to this in a moment, the FDA that you can actually accurately diagnose this diagnosis, that you can make this diagnosis, and that really complicates things. So with that as background, one of the concepts that I'd like to share is that if you start here, which is where we're headed in hopes to avoid a lot of the morbidities, And these are the big ones: early onset sepsis, necrotizing urine colitis, bronchopulmonary dysplasia, retinopathy diseases, and intraventricular hemorrhage. These are clinical endpoints, and as we already talked about, the genetic contributions of these are small, but there's a lot going on in the intermediate. And these are the intermediate phenotypes, which we think are best expressed through molecules. And you can pick your favorite molecule. In my case, it's metabolites, and there's a lot of reasons for that. They are reflective of a lot of medications that we give. They're reflective of a lot of the nutrition that we give, and these are profound covariates when we think about risk and predisposition to disease. Now, final thought on this slide is, while genetic input to this equation is quite small, as I said, development, when you're talking about extremely premature babies, is quite large. So how do we begin to deconvolute this problem? So thankfully, Dr. Wu spoke before me, and the Genetic Diseases Screening Program is one source of data that we have turned to over the past decade plus, because in reality, this is population metabolic data. And while it's looking for rare genetic inborn errors of metabolism, if we just confine the molecular space here to those metabolic diseases, in reality, these are phenotypes. These are metabolites that are directly tied to a genetic defect and a functional deficit in a baby. Moreover, the reason that this program works is because it's pretty accurately reflects an underlying problem of metabolism, and more importantly, it's actionable. Through a change in diet or another intervention, you can prevent the onset of the morbidity that is accompanied with the various metabolic defects. And so we reasoned is that we could take this data at scale and begin to ask some questions about acquired diseases of prematurity rather than inborn errors of metabolism, using metabolism as the common denominator here. So one of the first things that we did was we recognized that these publications by others, there was this recognition going on in the 2014-2015 era, is that premature babies had different threshold values for calling genetic diseases, which suggested actually that premature babies actually had different metabolism going on at different gestational ages. Extending that idea further, we published this paper back in 2017, and while we were able to get a sufficiently decent area under the curve, receiver operating curve here to get published, that's not the most important thing here. The most important thing here is what I have in the boxes, and although this was a somewhat dated paper at this time, the observation which was important. Babies' risk varies, as I said, by gestational age and birth weight. And 32 to 36 weeks, you can say, moderate risk, high risk for 32 weeks, and when you combine them all. The really interesting thing here is that if we just looked at the acylcarnitines, which are reflective of fatty acid and other organic metabolism, you could essentially get the same degree of risk as determined by a receiver operative curve as you could if you used gestational age and birth weight. So what that suggested is that the metabolites were reflecting the age of the baby using biologic features, and then we wouldn't necessarily have to now reside or rely on a marker on the calendar or on the scale. And this would now open up the opportunity to be able to understand how could we move these metabolic features, do interventions, and what would it mean, right? So to expand this a little bit further, before we're taking that into the newborn, I want to pause for a minute and say, well, what about mom's influence on baby? And this also provided an opportunity by, again, looking at the newborn screen. As the prior several speakers already mentioned, we have the fantastic ability to link to California statewide outcomes data at a really, really discrete level. So we can pair this data, we can harmonize it, and then looking at the newborn screens, we began to look at matched clinical data of maternal conditions, specifically the ones I was talking about: preeclampsia, hypertensive disorders, and diabetes. And when we did that, we then started to look at what would be the impact on the various outcomes. Starting with over 3 million births, 50,000 pairs, what we came down to was we had nearly 7,500 mother-infant dyads, of whom 3,300 had diabetes and 5,000 or so had hypertensive disorders. And we built several models. The details are not that important, but what this slide tells us, if you just look at the x-axis where the phenotype of the maternal disease is, and our ability to identify in the baby's newborn screen who had what. And what this shows you is that the more profound the maternal phenotype, if you agree with me just for a moment that type 1 diabetes is more profound, more long-standing than type 2 diabetes, which is more profound than gestational diabetes, which is acquired only during pregnancy, what you can see is that the effect on the newborn screen alone, again, just a population level screen and a description of metabolism, is more profoundly affected by the maternal phenotype and our ability to detect that just looking at the screen and say, this mom probably had diabetes of one sort or the other. Equally interesting is if you look at the hypertensive disorders, you get the same kind of pattern, which is you have pre-existing hypertension, gestational, mild preeclampsia, severe and chronic, and of course the most severe phenotypes in mom are reflected in the most severe phenotypes in the metabolic screen. So whatever's going on during pregnancy with these profound acquired conditions of pregnancy dramatically affecting baby and vice versa. Now this slide's a little bit busy. This is a review of the Neonatal Research Network data by Ravi Patel. They do this every 10 years or so. And in 2015, the importance of this is that there's a latency bias here, right? And so it's great to look at a newborn screen, which is when the baby is first born. The advantage is you're looking before any exposures, any interventions that we've done to the baby to alter their risks. But on the other hand, we want to predict those diseases like NEC and BPD that have a latency of onset of several weeks. And what we know is that NEC, as depicted here, I think it is in purple, and you've got BPD in blue. They come on in red, they come on at different times. So for example, at about a month to 2 months of age, you see a peak in necrotizing enterocolitis. So what's happening between that time that we're trying to predict it at birth or put babies into risk categories and the time that the disease is onset? And same thing for chronic lung disease or BPD. You get a peak after a month or so, and it's really defined currently as a clinical outcome of those babies who need respiratory support. So again, how do we deconvolute this? Well, the answer is you go to longitudinal data sets. So once again, just a kind of proof of concept, we went back to the newborn screen. This is a pediatrics neonatal network themselves. It was run at the time by Reese Clark. He had 23 sites in 17 different states, and he had already looked at differences in profiles and thresholds, but he did not look at the various disease onsets. The value was he had repeated this trick, meaning he did the newborn screen over and over again between day of life 0 to 1, 7, 28, and 42. So now we have the ability to interrogate this same screen at population levels across postnatal age to see if we can say something more precise about the onset of these various acquired diseases of pregnancy, of the newborn, sorry. So long story short, a lot of data summarized is that you could see inflection points as the baby started to transition from IV nutrition TPN into oral feedings. We were able to track and trend some of the various pairs and the ratios of the metabolites that were changing. We did, of course, the requisite heat map when you're looking at everything in aggregate. And we would be able to begin to look at very specific pathways of metabolites and their metabolism and begin to come with some very specific hypotheses that we could go on to test further. But the important thing here is the longitudinal study, and the magic really became is when you look in the right place. Now, this is a slide I borrowed from John Reese and Lance Prince. This is a study that's actually just getting started, but it demonstrates the value of doing longitudinal sampling. And what we're doing now is very dense sampling, and name your favorite ohm, but we're taking blood, we're taking tracheal aspirates, poop, breast milk, and urine, in the idea that we can provide for this longitudinal track record of biologic sampling in the neonatal intensive care unit. But the vignette of success that I want to leave you with is focusing in on poop, because again, close to my heart is this problem of necrotizing enterocolitis. And while we might be able to identify those babies either by gestational age and birth weight who are at risk, or more exquisitely by their newborn screen, it's when you start to look in the baby poop that we started to really find some things that were quite interesting. So I believe that necrotizing enterocolitis, and we've published to this effect, is a metabolic problem. We all know that babies' guts in the NICU are colonized with a lot of bad actors, and particularly of the taxa proteobacteria, which should not actually even exist, but they should be chock full of other things like lactobacillus and bifidobacterium. But it's what the bugs bring with them, which is what is their metabolic capacity, and what are they doing with the carbon substrate that they're ingesting, which is either formula or better yet, breast milk, is what produces those mediators that we're most concerned about. And the answer became only when we started to look at the metabolites in the stool, and we found a very specific pattern of metabolites that were produced in babies at the onset of NEC. And the answer to that question was formate. Formic acid is a single carbon, short-chain fatty acid. It is produced in abundance only by proteobacteria. That's your E. coli, your Enterococcus, and your Klebsiella, that should not even be there. And when they interact with the carbon sources and the fatty acids, and the oligosaccharides that they're seeing, they produce this in abundance, in particular when you have very poor peristalsis of the gut. And so in necrotizing enterocolitis, what we showed is that formate is produced in very low levels in babies prior to the onset of NEC. It spikes dramatically, and it goes away again when we give antibiotics, because of course when you give antibiotics, all the proteobacteria are exquisitely sensitive to the antibiotics that we give. They're suppressed, you take away the antibiotic, and those bugs came rushing back, but at least you've solved the short-term brush fire of the formic acid being produced. And we show through this nice correlation curve is that this is a marker of intestinal injury. It's a cytokeratin protein that we can measure in the poop. But there's a strong correlation between the formate concentration and the degree of injury. So putting this all together, what we published a number of years ago is that all the babies have gut dysbiosis. It's the option of what these bugs bring as far as their metabolic capacity and the genes they carry. And one specifically is this pyruvate formate lyase. which, rather than converting pyruvate and allowing it to be converted to lactate, which is a fuel source for the gut, it rapidly converts pyruvate to formate. Formate, in turn, hits the baby's intestinal lining and causes necroptosis by decoupling mitochondria. Talked to Daria Mokley-Rosen earlier today. They also, in the course of this being further metabolized, produces CO2 and hydrogen gas, which we see clinically as pneumatosis intestinalis. That's the clinical finding, how you make the diagnosis. No one ever has given an exquisite definition of how does it get there. The answer is you break down the barrier because of the formic acid and the gases diffuse into the gut. So we now have a potential explanation that it starts with dysbiosis, which in a baby is this abnormal colonization pattern, followed by their abnormal metabolic capacity to convert pyruvate to formate, producing cellular injury, and the clinical findings we know is necrotizing enterocolitis. And just to show you how we've taken this story forward, working now with an industry partner over the last several years is to move this concept towards a clinical trial, specifically to work towards colonizing the baby's guts with bifidobacterium, which will displace, in the setting of HMOs, human milk oligosaccharides, all those proteobacteria. So you prevent this from ever happening in the first place. And how this works is that if you feed a baby bifidobacterium, it rapidly will colonize their gut as long as they're breastfed. If you don't, they don't. And what this graph shows is that the relative abundance of mucin glycan is either dramatically increased in the stool or not there at all. What does that mean? It means that if we don't give babies the proper colonization partner, bifidobacterium, and feed them breast milk, they will eat the mucus layer of the gut and they will shed it into the intestine. And that's what's depicted here in the cartoon. So bad bugs, proteobacteria, they don't necessarily like the HMO and eat it. Rather, they're mucolytic and they break down the barrier, which of course then leads to the invasion. It produces the formic acid, which produces the picture of necrotizing enterocolitis. Conversely, feed a baby who is breastfed because you got to give it the carbon source it wants, which is the HMO. It's the oligosaccharide part of breast milk. Bifidobacterium come in and colonize. It gets rid of all the bad guys because it totally lowers your pH and lactate levels, which these guys don't like. And it produces a healthy mucus layer, and you don't get necrotizing enterocolitis. This currently, we've been designing this study with OHSU, Brian Scottolini and Brian Jordan, with a corporate partner to try to launch this into an FDA trial to colonize babies, talking to Valerie Chalk and some of our other neonatologists here to help lead this study. So again, by studying the differences in the short-chain fatty acids in the stool and linking that back to who are the colonizing patterns and what is the vulnerability of the baby, we can potentially change clinical care in this manner. Okay. Third point I'd like to make is that these are two papers that we are hopefully publishing, or actually that have been accepted into publication, of the new tools that we've been working on to more deeply probe the metabolome in order to get to phenotypes and some of the problems that I've been talking about. One of these, done with Nima Agapur, John Reese, a variety of others, and another one done with Mike Snyder, same crew, in Cell Reports Medicine, is an atlas. And the other one is, again, returning to the newborn screen to say, can we do this on a much larger degree? So let me just give you a few pieces on this. I know this is a terribly busy slide. Nima alluded to this earlier. Again, we work with very large data sets and we're able to get the raw data of the newborn screen from the GDSP. We compare that with the outcomes data and CPQCC data. In this particular study, what we did was after we built models in California, we tested them and verified them in an Ontario cohort through their newborn diseases screening program. And what this tells you is that some of the findings as far as the indices that we're able to build can be generalized across to other centers. And part of the reason this works, of course, is that the newborn screen is such a robust, reliable, and reproducible methods for producing the data in the first place, which allows us to then compare across different cohorts and different demographics. Very busy slide but very briefly what we do is we take all these different metabolic data and clinical outcomes and we compress it into a single layer in order to provide a master index so that you're at risk for, as we said, this is kind of akin to your gestational age and birth weight cohorting. We then take it a step further using a variety of machine learning approaches to say, can I look at every single individual metabolite at different quantiles and get to a variety of very distinct subcohorts who are at very discrete risks for each of these acquired conditions. And this is just a display of what the different relationships are and how they, if you spend some time and look at it, which we don't have, would show you the differences. But what this really shows us is that we can do a pretty good job across all extremely premature babies. And we compare this to the gestational age, birth weight, and the different calculators that come from the Neonatal Research Network. We do a better job. But then we take it a step further, and looking at these different quartiles, we can identify those babies at the highest risk, where we go from a potentially 10 to 20% lift in the overall AUC and the precision recall curves to really getting up to things that potentially would be clinically useful and meaningful. And we've done this across gestational ages just to show that that's not artifactual. Okay. This is, again, about to be published. What it explains, I think, or opens up the opportunity is the generalizability and the transportability of some of these metabolic indices to be done in other settings because of the robustness of the newborn screen. And then finally, we have now accepted into press what we're calling an encyclopedia of the cord blood metabolome, which allows us to interrogate maternal-fetal interactions and disease risk. A variety of my collaborators here at Stanford and elsewhere are listed here. Very, very quickly, the idea here is that what we've done differently is we've taken both arterial and venous blood, so we can speak to both fetal as well as placental side. You can look at gradients between them. We do a lot of biphasic separation, mass spec analysis, linear statistics, and machine learning. But overall, we have a data set of 832 metabolites and 559 lipids, which now allows us to do a variety of things. And among those is we can look at the microbial interactions of mom and how that's transmitted through the metabolites in the cord blood to baby. We can look at the various effects of mother's diet on, again, the cord blood metabolome and the effects potentially on baby. We can adjust the gestational age according to metabolism and the different mediators that we're reading in the cord blood. And we can, I think, perhaps most excitingly, is look at the effects of medications that historically we would not have recognized have a profound impact on that pregnancy and start to reveal those quantitatively and how that's working. Moreover, we can now see signals already of the acquired conditions of prematurity. I've told you a lot about that. Complications of pregnancy, other neonatal conditions which are far more prevalent and potentially less injurious, but gives us an early start on these that we can do interventions on. And as I said, what is really exciting to me is we can look at exposure to things like caffeine, acetaminophen. I hate to even mention that because of recent press. Not to suggest it's bad, but the point is at least we can now potentially do this in a more quantifiable way, because you can look at not only acetaminophen and its metabolites in a PK type study, you can look at the other pathways that it's affecting at the same time. So very, very quickly, just in wrapping up, AV gradients, these are global changes basically, and really profound changes in some cases in the preterm birth where you see dramatic differences in triacylglycerols. Had a lovely conversation with Yoel Sadovsky about the potential implications of this and uterine biology yesterday. So a lot more to be done here. This is chorioamnionitis. You can see the effect of corticosteroids and acetaminophen. But perhaps the most interesting thing is this, which is what I'll leave you to. A lot of people create their favorite metabolic clock. We've done the same thing, whether it's your metabolome, your proteome, your genome. We too have created one where you can say what's the actual gestational age of the baby based on last menstrual period, first trimester ultrasound, gold standard testing, and what do the metabolites tell us. And we can do this pretty well, getting about 88% certainty within 14 days is what this should say. And with a Pearson correlation coefficient of around 0.84, with more data, more patients, particularly at the lower ends of gestation, as you can see here, the data is much more sparse. This will improve. But the really cool thing is, as the final take-home message, a lot of the features that are driving this model are actually sex hormones, and stress hormones. And one of the observations that we have in this paper is that when beta-methasone is given, which is many times given to pregnant women in the last couple of weeks of pregnancy, when it's threatened to be preterm birth because it has effects on helping forestall preterm labor as well as lung maturity, we see a dramatic effect on the clock, if you will. So beta-methasone appears to be working to make the babies more metabolically mature by about on the order of 7 to 10 days. So that's pretty cool. So again, it kind of suggests that the tools that we're creating at the molecular level give us an ability to say, where is this pregnancy in the overall developmental scheme of things, and what is the medication that we're doing? Why would beta-methasone forestall labor? Well, at least we now have this intermediate phenotype where we can start to think about this at a much deeper level. So with that, I'll close. There are far too many people to name and thank individually, but we'll list a few things on the next slide. But the take-home lessons here are this. By studying metabolites as intermediate phenotypes, we think we can get closer to disease mechanism of action. We can identify new potential diagnostic and therapeutic modalities in doing so. I really looking forward to exploring more the effects of maternal comorbidities and the quantifiable effects, much like we did with that newborn screening. Very excited to look at medications and the effects, if not actually asking the question, could a new medication affect this pathway in a different way that we would be thinking about? And finally, some of the new tools. Again, this CoreDB is an encyclopedia. It's the beginning, not the end of a study. And this is going to be online with kind of an interactive website where you can ask specific questions of various cohorts and get various metabolic readouts of what we've already been able to observe, but a lot more questions and hypotheses to be tested there. Tons of people to thanks, including all of you for your time, and I appreciate the opportunity to speak.
Okay, I just have one question. I was struck by something you said in the beginning around the FDA diagnosis of NEC requiring that X-ray when maybe we have a lot more evidence now of formate and other signals that the baby might be on the way to NEC. And I was just wondering what those conversations are like with the FDA and sort of overcoming some of these barriers of precision medicine that might be coming.
Yeah, it's painful is the short answer. But and the reason is, again, because the diagnosis of NEC is this clinical constellation. And the problem with an X-ray is, if you ask a pediatric radiologist, is this baby poop or is it pneumatosis, you might get a different answer 50% of the time when you ask 10 radiologists. And so that's a really big problem when you're trying to do a FDA-regulated clinical study to get this approved as a drug. So we've come up with a rubric. They're asking us to test it on real-world data to tell us the observed to expected differential. You have to have panels of radiologists and concordance among neonatologists. So we're thinking of all the different ways to do it. The best way to do it would be if we had an objective molecular biomarker that everyone agreed on. That does not exist. There's a lot of things that have never been approved or developed further, including in my hands. I've developed several that I never pushed forward because of economics and other things, but that's really what's needed. And there's a lot of thought that goes into that. So at the moment, it's clinical features. The future is, I think, molecular features. Yeah.
I agree. Amazing. Thank you so much.
Thanks.
Okay, our last panelist here is Dr. Stephen Luby. He is a Lucy Becker Professor of Medicine and Infectious Disease at our School of Medicine, but holds a lot of titles across campus, including at the Woods Institute for the Environment and the Freeman Spogli Institute for International Studies. He is our director for Stanford's Center for Human and Planetary Health, which is a joint across the School of Medicine and our Dora School of Sustainability, as well as our director of research for the Stanford Center of Innovation and Global Health. Welcome. He's going to be talking about our interrupting maternal and child-led exposure in South Asia. Thank you.
Thanks a lot, Ryan, and thanks everybody for staying on. I hope that it's always a tough position right before lunch. But I want to switch us a little bit from talking about California and talking about Stanford to talking about the world. And I want to center this if we look at mean blood lead levels. And what we see is that mean blood lead levels in low and middle income countries are more than 3 times higher than they are in high income countries. And just to set your minds a little bit, the United States population is 4% of the globe. We take all high income countries together, we get 16%. So the world is the 84% who have elevated blood lead levels. So this means that 632 million children globally have blood lead levels above the WHO demarcation as a cause for concern. 632 million. Now, pediatricians and obstetricians have been studying lead and its impact on childhood for a long time. These are old data from David Bellinger back from the 1979-1981, enrolling 249 children from Brigham and Women's Hospital in Boston, collecting umbilical blood cord lead levels. And then they evaluated these children every 6 months using the Bailey scales of infant development. And they were careful, controlling for 12 potential confounders. And what you can see here is that, across all 3 groups, the Bailey scores increase as child grow. They have more mental development. But you also see that the children that have the lowest blood lead levels were consistently outperforming the children who had higher blood lead levels. Now, of course, it's difficult to separate in these studies how much of this impact on the child's future development was a result of what they were exposed to in the womb and how much of this was what they were exposed to subsequently in the environment. At least within this classic study, the mental development index score was associated with cord blood levels, but not with subsequent child blood lead levels, suggesting that lead exposure in utero was particularly damaging to the developing brain. More recently, there's been a review of 12 studies that have looked at prenatal blood exposure and child development. In 10 of these studies, they found adverse neurocognitive outcomes associated with gestational lead exposure. 3 studies found no association. Now, when I look at these data, they have lots of different measures of child outcome. And so the 3 studies that find no association also are looking at somewhat different outcomes. And again, these mixed populations of many different adverse exposures. So I look at this data and I say, I think we're seeing a signal that's actually quite strong about the adverse impact of lead during pregnancy on child development. And these are data that are very strongly supported by animal studies as well. But we have more recent data. We've had unleaded gasoline mandated in this country since 1979. You can only have very low levels of lead in gasoline if you're driving a car, unless you drive for NASCAR. If you drive for NASCAR, you can have lead because you want the cars to go fast, right? So a typical race releases 30 to 40 kilograms of lead into the environment. Beginning in 2007, NASCAR made a decision, and they said only unleaded gasoline was permitted in NASCAR race cars. So economists, including Linda Bui and others, have said this is a pretty remarkable natural experiment. There is an abrupt reduction in lead exposure. So you see there, that's the Charlotte Motor Speedway. And so you could look at the outcomes of children, since they have 2 races a year. All children are going to be exposed in utero to one of these 2 blasts of lead into the environment. And you can compare people who live at various distances to Charlotte Motor Speedway with those in the 5-county area that live farther away, more than a 10-kilometer buffer zone out of what they were analyzing. And here's what they found. What you see here is that in the time frame from 2004 to 2006, that is, when there was lead in NASCAR, you can see that these children are substantially have lower birth weights compared to children living in that same area in 2007 to 2009, after lead was no longer allowed. So we have a very strong signal on an important neonatal outcome, birth weight, directly related to lead exposure. So Stanford loves its biomedicine. Carl, I liked your talk and all the omics and all the heat maps, and I'm trying to get this all in. And in fact, there's a whole biomedical research agenda that says maybe we should really try to understand the full array of the harms of lead exposure and their underlying molecular pathway. And if I were a biomedical researcher, that's probably what I would talk about. But I'm a public health doc. And when I look at this, I say the data are really compelling about how horrible lead is on child development. So I think that we should ask, where's the lead coming from? Why is there so much higher lead in lower and middle income countries? And how do we interrupt it? So in 2004, I moved to Bangladesh. I was deputed by the United States Centers for Disease Control to work on emerging infections. Working on infectious disease, emerging infections for the US government. But every week, the institution that I was deputed into, the International Center for Diarrheal Disease Research in Bangladesh, published abstracts of all the work that had been published in that last week. And one of the articles they published was about 329 children living in rural Chandpur, Bangladesh, who had a mean of 6 micrograms per liter of lead in urine. And although I'm a communicable disease epidemiologist, I had worked earlier on lead in Pakistan, so I knew these data. This just didn't make any sense to me. I knew where this population lived. Rural Chandpur is a bunch of rice fields. I mean, there's rice fields, and there's more rice fields. Gasoline had not had lead in Bangladesh for over 10 years. There's no paint in the houses. There's no glaze on their dishes. So started looking in the literature. A year earlier, there'd been a study in rural Dinajpur, again, 183 school-age children with elevated blood lead levels, and their parents with elevated blood lead levels. And again, no obvious exposure to lead. What was going on? So in my mind, I said, we got to figure this out. It just doesn't make sense to me. There's got to be something out there we're not accounting for. So we were interested in evaluating the severity of lead poisoning in rural Bangladesh. We didn't think these two were outliers, and we wanted to identify the pathway of exposure. So we were doing another MCHRI-like big study on pregnant women in 4 districts in rural Bangladesh. We were enrolling 6,000 pregnant women and following their children now. We've been following for 10 or 12 years. We added collection of a heavy metal-free tube of blood from mothers at baseline and ultimately secured money to evaluate 430 of them. And what did we find? Well, we found that pregnant moms living in rural Bangladesh had elevated blood lead levels. I mean, look at the tail. Look at how many have quite elevated blood lead levels. And there's no safe level of lead in your blood. So all of this is bad. It turns out, though, that it's really hard to link human lead to a particular exposure. And there are many reasons for this. One of the reasons is that lead is stored in bones, and once it gets there, it has a half-life of greater than 10 years. Now, moms who are pregnant might be mobilizing more blood. They're more calcium from their bones, and with that calcium, more lead. There's some equilibrium with the blood. And the current blood lead levels may reflect recent or then long ago exposures. So we basically went at this in a very multidisciplinary way. We used anthropologists, we used epidemiologists, we used, the anthropologists were to go in and to find out what do people say they're being exposed to. We used epidemiology to look at what are the exposures they reported and where did we see higher blood lead levels with those. We used environmental scientists to help us understand the various potential sources of lead, and geochemists to actually understand more about lead. And as I say, I had a broad team, but I want to particularly call out Jenna Forsyth, who was a PhD student at the time and now runs our project Unleaded. And I would say that initial investigation, we found no paints in homes, no glazed potteries. There was traditional medicine, but it wasn't linked to high blood lead levels, and the tested samples didn't contain lead. So Jenna got very interested in turmeric. And I said, I'm not so interested in turmeric because I'm an epidemiologist and I don't see any difference in exposure. But that's because everybody in Bangladesh is exposed to turmeric. And she got about a dozen samples. She found one that had elevated blood lead levels. I'm like, I don't know. So she looked at the US recall data. And the FDA, they didn't give a lot of details, but they had 9 recalls of 17 brands over 6 years. All but one were turmeric, and all were from India and Bangladesh. So we start looking at turmeric. Turmeric is in the lily family, and it's actually the root there, the bulb there that we eat, and you grind it up, and it makes that nice yellow powder. And so when it's first harvested, it kind of looks orange like that. Then it's dried. Maybe doesn't look so nice and brown, so you might polish it a little bit, bring out more of the yellow color, grind it up, and then it's sold. So to evaluate turmeric in Bangladesh, the team systematically sampled turmeric from 4 districts at retail markets. And they analyzed both for lead and chromium using ICP-MS. Expensive stuff. We had to ship it to Stanford to get it done. And so if we look at the roots that just came out of the ground, we found no lead. If we look at the roots that were polished, we found some of them had very high levels of lead. The ground spice, some contaminated, the packaged, less so. So the 340 samples collected, 20% had elevated lead. So the anthropologists went and started to look at what these processors were doing. And you can see they were adding this pigment. And you could find this pigment all over. And yeah, the roots really did now look bright yellow. And we found that polishers added yellow pigment in 7 of 9 districts. And all the turmeric and all the yellow pigments contained elevated chromium. So if this were just coming from lead in the soil, it wouldn't have chromium. The lead in turmeric was lead chromate. So learning, but still figuring out, yeah, but how do we know if that's the lead that's actually in mom? So it turns out that there are 4 common lead isotopes. There are 3 that are radiogenic and 1 that is stable. And the ratio of these different isotopes can indicate age and origin of lead. So the sources of lead may have distinct isotope ratios. And this was important for us because we were looking at moms were also sucking on clay or soil during pregnancy. We found some tin soldered cans that were soldered with lead solder, and we had turmeric. But if you look at it, actually the ratio of lead-208 to lead-204 was different in these sources. And when we tested blood, it aligned very closely with the turmeric. So the lead in blood matched the lead in turmeric. So who was doing this and why were they doing it? So again, we led with our anthropologists, went now to the major turmeric producing districts and interviewed 10 to 20 members of the supply chain in each district. And they said some customers prefer yellow turmeric. The polishers added what they called puri, which was lead chromate, at the request of wholesalers. And it had been a common practice since 1988. So this is going on for 25 years. Here's nice turmeric from the south of the country. Look at how bright yellow that is as he breaks open the root. They say if turmeric gets wet in the rain, no matter how you polish, good color will not come out. Then you have to add color in order to sell in the market. There were limitations to enforcement of food safety. There's not particular attention on lead. Inspectors would only come during the day, so the polishers began working at night. So how we engaged is we did early dissemination of results to stakeholders, including visiting turmeric polishers. We went to each turmeric polisher and we talked to them about the impact of lead on child development and on the intelligence of the future of the children of Bangladesh. And then we also talked to government representatives in Bangladesh food safety. We gave deep debriefs and we shared the preprints with and the local ICDDRB press release with the government. So we did what academics do. We published the data demonstrating that the lead in blood was equivalent to the lead in turmeric, and we also showed the data on how this was getting contaminated and why. And so Stanford does what Stanford does, put something in Stanford News about what we're doing. But much more importantly was the pickup in Bangladesh. This was very big news. These are front page stories talking about this, much discussed. And the government jumped right in. They promulgated a new regulation that colorants were not allowed to be added to any spices. They printed 50,000 leaflets on what people could do to prevent this. Those leaflets were based on a study that we had done demonstrating that it reduced exposure. And the messaging was lead is dangerous and specific advice on how to reduce. The Food Safety Authority then, accompanied by a mobile court with national television watching on, visited the largest spice market in the country, and they had asked members of our study team to accompany them, and they were particularly interested in carrying our X-ray fluorescent metal detector. And that had just really changed our capacity to move quickly. So on national television, they tested spices in the market. Two shops were fined $9,300. The turmeric was collected and burned. Not what I would have recommended be done with it, but you know, partners are going to do what partners are going to do. And so if we now look, prior to the intervention, 47% of, and on the major bazaars across Bangladesh, 47% of the turmeric samples were contaminated. After the intervention, that dropped to 5%, and the following year dropped to 0. So basically eliminated it as a source of exposure. We went up to those same 4 areas and followed pregnant women now, what were 10 years later, that were 3 years after the intervention, and we see a 28% reduction. And you might say, why isn't it bigger? It's because of that long half-life of blood in bone. So is this only a problem in Bangladesh? We chose 23 cities across India, Pakistan, Sri Lanka, and Nepal. we employed undercover shoppers to visit the largest wholesale markets and the largest retail bazaar in the city. And we purchased turmeric and tested it. And what we found is the problem is not limited to Bangladesh. But we also see it in India, in Pakistan, and Nepal. So more recently, because of the large population in India, we sent undercover shoppers in 104 cities looking at both turmeric and other spices. And what we find, after looking at over 4,000 spices, is that 234 samples had lead concentrations exceeding India's standard. 7% of turmeric samples with lead. None of the other spices had lead levels above 10 parts per million. So if we look at Indian cities, we see that many people are living in places where the turmeric they're buying in the market is at risk of being elevated with lead. So lead exposure is a major threat to child and adult thriving globally. Identifying the specific sources of lead that contaminate children creates opportunities for effective interventions. I've talked to you about our work on lead and spices. We're also working on lead-acid batteries and other sources of lead. And I'm happy to announce that Open Philanthropy has given us $10 million in support to expand this work across the region and even into East Africa. Thank you.
Hi, I have one question. This too high for me. Yeah, this is fascinating story, and I was just wondering. You said that 86%, right, of the world is exposed to lead. So can you just comment a little bit? Now you hinted at the end. What about like in sub-Saharan Africa? It's not turmeric. What are the reasons for higher levels, and what interventions can be done?
Yeah. I mean, the reality is that this notion of going in and trying to do what we call the attribution study is something that people just hadn't tried before we went to rural Bangladesh and did it. So, so we think that there's a very high need for more attribution studies in different places, and that's part of what we've been funded to do, and trying to develop the capacity to do these studies. It's not a simple algorithm to try to figure out what is going on in this space, and how do we get population representative samples, and then how do you think back about what's going on, and the ability to use both qualitative methods and follow supply chains and quantitative methods. That mix of skill sets is, I would say, it's an unusual combination in these countries. So that those are capacities we're working to build.
Interesting talk. So lead screening is something that's an inexpensive test that we do in the U.S., but are there areas of the U.S. where you see gaps in lead testing, and around the world, countries that are not doing lead testing in pediatrics? Yeah,
there's no lead testing in Bangladesh. It's an expensive test where we now have ICDDRB is committing in the first quarter of 2026 to offer it as a test. But it's also a problem when your entire population has high blood lead levels. The solution is to lower the exposure in the population. I mean, it's not so much of a clinical issue. And I think, yes, we definitely see heterogeneity in the U.S., and I think it's kind of the same disparities that we heard about with disparities in California. Yeah.
Thanks. Maybe I'll also
the usually marginalized groups are marginalized.
UK does not do lead, does not test for lead, and of course it's a major lead producer, for making a lot of musket balls during various wars. So it's an unappreciated problem. There's probably a lot of lead toxicity in the UK.
Yeah, 83% of all lead in the global economy is for lead-acid batteries. And so if you started your car this morning, you started it with a lead-acid battery, when that lead-acid battery goes defunct, we don't recycle lead-acid batteries here. No, we send them all to Mexico, where the rules are weaker, and we consistently find that lead from lead-acid batteries is not safely processed, and so it's exposing. So you might even, it's not only your own population, but there's also an international justice issue here.
Really terrific work. Thank you so much for sharing it. Finally, before lunch, we just have one more speaker, Jonathan Coslet, who's our chair of the board of directors for Stanford Medicine Children's Health Lucille Packard Children's Hospital, is going to share a few words on LPCH. Thank you.
Thank you. Good morning, everybody. So let me get a couple notes up. So yes, I'm Jonathan Coslett. I am the chair of the board of Stanford Children's Hospital. I've been involved as a board member for over 17 years, so I've witnessed the incredible growth and evolution of Stanford Children's. That's actually half of its life, since Stanford Children's is about 35 years old. And it's truly amazing that an organization as young as this has become a world leader. And thank you guys all for everything you do for mothers and children. We all really appreciate it. The mothers and the children really appreciate it. Let me share some information around Stanford Children's Health, just to provide some context for all of you as you're working. And let's start with how we think about our 10-year strategic plan. We've developed the following 5 pillars that every strategic and operational objective must satisfy. Number 1, we will always be a market-leading academic medical center. Number 2, we're committed to equitable and compassionate care. Number 3, we want to have a diversified and robust service portfolio. Number 4, we want to be the employer of choice. And number 5, we want to have an enduring and sustainable financial picture. And our highest areas of focus are heart, cancer, mother and baby, and surgery. So now let me share some facts about how many lives we're impacting at Stanford Children's Health. 600,000 clinic visits a year, 10,000 inpatient and outpatient surgeries, 15,000 inpatient discharges, 5,000 babies delivered. 40% of our patients are Medi-Cal families, and about 10% of our patients are from out of state. Those are usually some of the toughest cases where some of our unique expertise is provided to those patients because they can't get them in the area that they live. We have a 2.2 times case mix index, which is among the highest pediatric case mix indices in the world. And financially, we're very strong. We have saved about $1.4 billion in our endowment. We generate revenues of about $3 billion a year and cash earnings of about $150 million, of which we reinvest all of that back into all the facets of capability and care. And of course, given the changes in the federal bill, the big bill, we will face pressures on the reimbursement side for our 40% of our patients who are Medi-Cal families. But fortunately, we have an exceptional management team led by Paul King and a really talented and committed board. And we're currently working very thoughtfully and very diligently through how we're going to continue to manage through these evolutions. I want to share 2 patient stories that bring to life the amazing care provided every day at Stanford Children's, which all of you are a part of. First, a young girl, her name is Michaela. She was born with a terminal heart condition, restrictive cardiomyopathy, and she needed a new heart to survive, but none were available. So for over a year, we provided her with the care and with a device, a bypass and circulatory device that was mobile. So she wheeled it around with her as she lived her young life. Ultimately, a heart became available, and our team successfully transplanted that, and today she's doing very well. Another interesting case, Audrey. Audrey was not recovering from routine pneumonia. The care that she was receiving, she was diagnosed with very everyday types of diagnoses, but she just wasn't recovering. So she came here, and after lots of persistent exploration, it turns out that our team discovered she had a rare genetic disease called hemophagocytic lymphohistiocytosis, HLH, since I probably mutilated that disease, actually, that disease name. So she had HLH, and this disease caused her body to be unable to fight off essentially all types of very common diseases, liver, pulmonary, and many, many others. And she had to go on dialysis. She needed a bone marrow transplant, so she had one from a third party. Unfortunately, her body rejected that, and she got sicker and sicker. So for well over a year, almost 2 years, our multidisciplinary team cared for her and managed all of the different and challenging conditions that she had, so that she can become strong enough to receive a new bone marrow transplant, this time from her mother. She did ultimately receive that bone marrow transplant thanks to the fact that she became strong enough, and that worked. She's much healthier and stronger now, and she's in good position to receive a liver transplant sometime soon. She's also doing really well. So those are just a couple of cases that happen every day at Stanford Children's Health. And so we all in the Bay Area and indeed in the world are so grateful for the incredible research and clinical excellence that's being created for these types of life-saving and life-changing therapies delivered by our exceptional doctors, nurses, and staff. And MCHRI is a really big part of that, and we're very appreciative of all that you do. So I just wanted to provide that as context as you're doing your work, as you're thinking about the research and the care and the therapies that you're providing. Stanford Children's Health is a pretty exceptional place, and we are really grateful and lucky to have all you being a part of it. Thank you.
Thanks so much. All right. Thank you for those wonderful words, Chairman. And so now that's closed session 2. It's time for lunch. There's also, thanks to the volunteers, have taken down poster session 1 and put up a whole new set of posters for session 2 for the next hour. So you have your work cut out for you to eat lunch and learn all these amazing things for the poster session 2. We'll be back in 1 hour, where Mary will then present the Visionary Leadership Award to Virginia Nguyen. So see you in an hour.